with Professor Dr. Mohamed Magdy from the WEGE University.
Assalamu alaikum. Good morning, everybody. First of all, I want to thank my dear Nada and Shayman Shakir for their invitation for me to be here today with you. Today, my topic's about IBD emergencies. I think now we have an era of IBD. We have increase of the number of patients of IBD. Of course, not all gastroenterologists should doing IBD, but we should have at least the basics about IBD when we can detect a case of IBD emergency. It's IBD as two types of IBD, UC and CD. It's a disease of remission and exacerbation. And of course, sometimes with exacerbation, maybe a severe exacerbation to have symptoms or conditions, maybe a life-threatening. Yes, it's small, but it's an important segment of IBD associated with acute, severe, sometimes life-threatening complication and require immediate medical intervention. Some emergencies related to UC, like severe acute ulcerative colitis, toxic megacolon, or massive hemorrhage, and even perforation. Other more related to the CD, like intra-abdominal sepsis or abscess, bowel obstruction, perforation, massive bleeding, sepsis. Some critical cases not related or not related to the intestinal complications, like thromboembolic events, hepatobiliary, and ocular emergencies. I think we should have an idea or basic to detect the emergency. When we can see these patients have an emergency case and I should hospitalize the patient and take care of him to avoid the life-threatening scenario. A patient with sudden severe abdominal pain not responding to treatment, sudden increasing in the number of stool or bloody stool or even massive hemorrhage from GIT, high fever, severe manifestation of dehydration or manifestation of sepsis or a sign of abdominal obstruction or surgical abdomen. Of course, first of all, you should have your patient in the hospital. The general investigation should be done, CBC, C-reactive protein, ESR, serum electrolytes is very important, liver and kidney function, fecal calprotectin should be done if available, and if you have high suspicion of infection, we should go to blood culture and stool culture. Even Clostridium difficile toxins, it should be examined. Imaging is very important, especially in the diagnosis of emergency. I'm not talking about diagnosis of IBD, I'm talking about emergency. So any patient, she should go to the imaging as soon as possible. CT abdomen with contrast, intestinal ultrasound if available, MRI, in some cases of intestinal obstruction to differentiate between it's fibrotic or inflammatory. Even short colonoscopy can be done, but without preparation, with an expert to avoid a complication or a high suspicion of perforation. One of emergencies is a toxic megacolon. Like we see, we can just by X-ray diagnose and CT we can confirm. In the patient with related emergency, IBD-related emergency, we should start as soon as possible the medical and the nutritional support. Of course, you, as a gastroenterologist, you don't need to be shoulder the whole responsibility. It's not, you are not a hero, not a one-man show. You should have an MDT. Even if you are asked your colleague of gastroenterologists who are doing a lot of cases of IBD, and also you should have radiologist, surgeon, nutritionist, ICU team to have a good care for those patients. IV fluid and low molecular weight heparin is mandatory in patient even with a bleeding. Sometimes we are afraid to have a patient with excessive bleeding, but prophylactic low molecular heparin is mandatory. We have a high incidence of thromboembolic manifestation. Antibiotic, it's not a routine, but when you suspect infection, you should manage with empirical antibiotic. Treatment of IBD emergency, it depends on the type of emergency. In acute severe ulcerative colitis, you should stabilize the patient. Intravenous steroid is mandatory, but take care if your patient not responding and the third day on the IV corticosteroid, you should go to biological treatment. If you have a good experience with cyclosporin, you can start, or go to the one of the anti-NF like in infliximab, it's rapid action, or now we can also use the small molecule like JAKs inhibitors. In case of intra-abdominal infection like abscess, uses of biologic or immune modulator sometimes may be a risk for increased sepsis. But if you drain the abscess or you relieve the sepsis, you can go to the biologic. Is the intervention radiology have a role in some cases of intra-abdominal infection? Yes, we can. If you have a large abscess, you can use the intervention radiology before go to surgery and use the empirical antibiotic. If the abscess less than 3 centimeters, you can try to empirical antibiotic. If the patient responds, it's okay. Nutrition support. In those patients, it's better to start nutrition support once you have your patient in the ICU or in the hospital, as most of patients have a deterioration of the nutritional condition. So if you could start the enteral nutrition, if no contraindication, if you're not preparing your patient for emergent surgery, you can start the internal nutrition. Otherwise, total parenteral nutrition may be the solution in that case. Don't forget surgery. Yes, we are gastroenterologists. We are going to our medical treatment, but sometimes the surgery is the life-saving for those patients, especially in cases of acute severe ulcerative colitis not responding to treatment, even with biologic treatment or urgent biologic treatment, severe bleeding, patient with toxic megacolon. If you see the algorithm, if the patient is clinically deteriorating, go to the surgery, don't delay. But during the supporting treatment, if your patient going well and showing rapid improvement, we can give him some time. If complete improvement, you can continue. But if failed, go to the surgery. Of course, if a perforation, it's a surgical condition. Usually, don't delay on those patients. If you go early to the surgery, you have a good result. But sometimes if you have a small perforation with localization or abscess localization, you can try to do drainage firstly and see if you will need surgery. It will be elective surgery. Intestinal obstruction, of course, it's different if it's intestinal obstruction in a case of ulcerative colitis from Crohn's. Ulcerative colitis, usually a disease of large bowel. If you have a stricture, intestinal obstruction, you may suspect something like malignancy. It's better to do good evaluation for the patient before surgery. Maybe the surgery differ according, is it a malignant or benign stricture? In Crohn's disease, usually you have a stricture in the small bowel. And of course, if you could differentiate, is it inflammatory obstruction different from fibrotic obstruction? If it's fibrotic, you should go to the surgery and resection. Medical sometimes response to biologic treatment. In the extra-intestinal emergency, as I said before, we have something like thromboembolic manifestation. It's very important to be careful. Yes, it's rare. It's about 1 to 6%, but it's important complication, and you should deal with it as soon as possible. Ocular complication, maybe it's not an emergency at the time of the diagnosis, but if it's untreated, maybe to have a big complication like blindness. Hepatobiliary complications. Hepatobiliary complication usually associated with ulcerative colitis, and it's emergency related to a case of a cholangitis infection, which may be life-threatening. In conclusion, evaluation and stabilization of the patient by MDT team is at the first line of management. It's the first step to have your team to have a good decision in the right time to save your life. Medical and nutritional management should be started as soon as possible. Early decision of emergency surgeon is recommended in case of cases of toxic megacolon, perforation, sternal obstruction, surgery in cases of SAUC and intra-abdominal abscess or fistulization after failure of medical treatment and urgent biological treatment. And thank you for your attention.